screen. So let me do that. Okay, and let's go to my slides. All right. So what I'll be talking about is encounter document creation. It's kind of in the context. I'm here on behalf of what's called the Joint Document Content Work Group, which is a group formed from the from members of Care Quality and Commonwealth to attack common pain points and to work through them. And the output of this, in some cases, ends up with groups like with structured docs. But there is also a layer of specification that that exists that we can write requirements for as well. That's more implementation related, and so that's the same layer as like the care quality specs or the Commonwealth specs. This would just be joint specs that would be adopted by each of those exchanges. So finding where to put the requirements is tricky. Just like we have the issue when we have things from the IAT, and do they go in the companion guide or do they go in CCDA or something? I'm going to zip through the description of the Joint Content Work Group because this is just background stuff. If you want to read about that group, you can. They've put out a version 1.1 so far of guidance, and we're on the next iteration of that. So let's talk about some of the challenges that we've had with encounter summaries. Here are some kind of user requirements that we gathered. First off, what's not listed here is that we have a need for encounter summaries to go through revisions. And the canonical example that we get is where you check out of a hospital and you get a discharge summary, and then at some point later, your labs come in and the discharge summary document is updated. So within that realm of having to deal with updates, we derived a whole bunch of other requirements. One thing, which is consumers want to get the same document if nothing has changed. This they were finding that when systems were generating documents dynamically, that they were sometimes they were generating a new document every time somebody asked, even if there was all the same data in it. And then this looks simple, but this next bullet is a very difficult one. We won't get into it too much, but they wanted to know without retrieving if something has changed. And so that's kind of outside of the CDA itself. It's more to do with the metadata. So we won't talk about that today. For the generators of documents, they wanted to know when it's appropriate to share an encounter as an encounter summary, when during the life cycle. They also want the ability to if they choose to proactively create and host documents. We even have use cases for paper documents that are scanned, or generate documents when requested, which is by far the more common case. And then they want to be able to never generate a document if never asked for. So you can see that these pain points kind of cross the lines of content versus the relationship of content to how you query for it. And then this one gets its own slide because as we talk through this, we realize there are a bunch of confusion around legal authenticator. In the base spec, it's the only time that the document is spoken of as being completed is adding the legal authenticator. And then we found that some systems don't populate this by default. So they'll respond and they'll generate an encounter summary, but unless you've set it up to do so, they'll just give you an encounter summary that maybe the only way that you know it's done is that there happens to be an end date, or it might be authenticated. You have an author, but it might not have a legal authenticator. And so some systems do use a single configured person. So it might be a HIMSS manager rather than the clinician who attests. And it seems like this was envisioned. I looked into, I went back to the Keith Boone CDA book to kind of learn about this. And and it may be that this is appropriate. I want to ask this group about that. And it may be use case dependent. So I looked at the attachments IG where a legal authenticator is required. And because I saw that was called out by the new version of the companion guide. So with all that confusion, here's what the clinicians in our group, they decided. They said, at least for treatment, you must share after the encounter is done. In other words, if the encounter has an end date, and someone requests, they didn't want you to not return it. But actually, I'll show that. I'm going to show that on a nice animated slide, so you'll see that. They weren't okay with waiting until it's been legally authenticated to share because of the issues we identified. And you might have some cases where you want to share a document that's in process, like even while you're in the middle of a hospital stay, much more common in an outpatient situation where you share a progress note while the care is ongoing. And then we did have a question for this group where discharge summary is required to have a discharge date. Could you use no flavor for that special case? And then they also decided anytime that data changed, they wanted a new document. You must share all updates. So then we talked about these three kind of things that could mark an encounter as done. One would be the end times available, one would be that you have an authenticator, and then you've got legal authenticator. And then I did want to call out this little section of the CDA book, which the little orange sections that I've highlighted, talking about legal authenticator. This at least talks about some organizations may only want to share legally authenticated documents. But then it says later, as more health information systems are developed that automatically produce clinical documents, this restriction on release is often relaxed for those. When I read these two highlighted requirements, it made me think that, you know, maybe the vendors configuring like a single HIMSS manager to be the legal authenticator, maybe they're right. Maybe that's really the appropriate thing to do, because what you're attesting to legally is that you've got a system that correctly captures authorship and correctly captures all the little intermediate steps where physicians are saying, yes, I said this, yes, I said this, yes, this is accurate, and that the act of assembling it into a document is being done by a device, it's being done by something that the HIMSS manager has, they're legally saying that it's okay to do that. So maybe that's the right way to go. I'd be interested to hear what this group has to say. Now, I want to show you, this was a diagram that we used to talk through these cases. And I'll explain briefly what this means. Let me just kind of look at my time. Okay. This is kind of a graphical display of the life of an encounter. So you could say the leftmost barrier is the very beginning of the encounter. So we know the effective time low, and then the encounter proceeds through time. So clinical events happen, you know, early in its life. There's lots of information happening within the context of the encounter. And then at some point, it ends, and you have an effective time high. But after it ends, you could still have things like updates to encounter. So the little blue arrows reflect that there's changes being made to the encounter data. Okay, we haven't yet talked about whether we have turned this encounter into a document yet. It's just from this level up, we're just talking about the data in the EHR or in the HIE. So we have an update to the encounter, and then at some point, we potentially have it become legally authenticated. And then even after that, you might have a correction, and that's what that red arrow refers to. And if you have that correction, I'm not actually sure whether you can make a correction to that legally authenticated document or whether you have to fully replace it. I'm not sure. And then the green arrows reflect queries that would match this encounter. So this is a little bit out of this group's realm, but this would be like, I'm looking for encounter documents that are within this date range, and And so it's a query that could conceivably return this encounter. And so we asked the group, how soon, you know, for which of these queries, 1 through 8, should it be a may or a should or a shall that you'll return a document in the life cycle of the encounter? And so we created 4 hypothetical responders, and we said, are they all valid? Are these all valid? And so the purple arrows refer to you returning a document, an encounter summary, and the white arrows mean that you're returning the same document. So you're saying, here's the same document again. You're not generating a new one. So each time you see a dark purple arrow, it means you've generated a new version of the document. So hopefully that is clear how to read this. And what I'll animate now is what the group decided. And before I do that, does anybody have any questions? Do you follow the diagram?
Joe, this is Lisa. A clarifying question on that white arrow that's in the 4th row down. Is that saying that if someone queried for this encounter document prior to some updated lab information coming in, and then the system queried for that encounter again after the updated lab information had come in, that the responder would get the same document, I'm guessing the document that did not have the lab information in it?
Yeah, that's a good question.
Up to
You're talking about responder B?
That, right there. What does that
Yes.
mean?
Yeah, so what it means, here's the heuristic. If you responder B is going to share the encounter, they're going to start sharing the encounter once there's an end date. That's their first thing. Then they're going to share, they're going to give you one version once it's signed off. Then they'll give you every version if any change. So they're specifically saying, I'm only going to return a version, you know, one version after it's ended and another version after it's authenticated. So they're specifically choosing to throttle the versions that they return. And I added this as I expected it to get pushed back, and sure enough, it did get pushed back. But I wanted to illustrate that this would be an optimization based on, you know, systems not.
I just wanted to make sure I was understanding it correctly.
Yeah,
so that white arrow means the encounter that ended, whatever you saw right there, even if new information comes in,
correct,
no one querying will receive that until, in fact, there's a big triggering event that the encounter is signed off. And at that point, the document that you receive would have any of that incremental data in it.
That is accurate. And the white arrow at the very bottom row is a different case. That white arrow reflects that between queries 3 and 4, there wasn't a change to the data. So between 5 and 6, there was a change to the data. Okay. So
yep, thank you.
All right, great. So so you can see the different heuristics by which these different responders are acting. Well, this is what the group decided. The first thing they decided was that waiting until it's signed off was too late. And they wanted to make this a shall. They said, if you have an end date, you have to share it. Now, after reviewing, like I said, in the use case of payment, that is in direct conflict. So I said, well, maybe this needs to be a should and not a shall. And the way I've got it written right now is that I'm limiting it to the use case of treatment. So in the case of treatment, you have to share. So it's good to share at the end of the encounter. So that's what they agreed with. And then it's also good, it's okay to share early in some cases, even though they all said, yeah, that's probably a special case. It would probably require a, you know, a physician would have to say, yeah, I really do want to share this now and do something positively rather than just passively. Like queries 5 and on, I think they all assume that this should just automatically happen. You know, the EHR should just automatically generate these documents and return them. Okay. And so this is kind of a paraphrasing of the requirements that we came up with for when to share. Okay. And so I'll let you read this and discuss whether or not you think we got it right.
So what's the may share for an encounter that's in process? So if you received one of those queries, 1, 2, 3, 4, and you were a responder that didn't share until the encounter was done, you basically would just not return. You'd say, I don't have anything about this encounter yet.
Yeah, yeah. So if there's nothing here, it means you're like, yeah, I don't know. It means you don't return any documents for that query. So the may is covered by responder D.
Yeah, yeah.
Yeah.
And Joe, while people are looking at that, I just wanted to call your attention to the comment that Dr. Lane made, that it remains an open question as to whether release of an unauthenticated document will be required by the information blocking regs.
Ah, good point. Good point. Was that made right here? Oh, Stephen Lane is on. Great. Glad to have you, Stephen.
And he's in the chat. That's why I wanted to call your attention.
I'm here, just trying to stay quiet.
Okay, great.
Sorry, for those of us who may not, what does that mean, information blocking regs?
Oh boy, that's a long discussion. These are the regs that were promulgated by ONC back in March that require certain actors to support the access, exchange, and use of all of the data in the U.S. core data for interoperability data set as of November 2nd of this year. The US CDI, as it's called, includes 8 specific categories of clinical notes,
right,
including the ones we're talking about here, presumably. So there is a requirement to release that data when it's requested.
Okay.
That's very helpful.
So that might change, Joe, if that might change that may to a shall if they're going to require those?
Well, not necessarily. It would depend on how the regs are written. I don't know if they would go so far as to say you shall be responder D. You know, like you shall respond with information about that encounter at any point in its life cycle, or if they would just limit it to after you've got an effective time high.
Sure. Okay.
But is this, I mean, I think, Lisa, you said that there has been a lot of discussion about, you know, how mature an encounter needs to be. Can we do better than this? Can we say something about maybe progress notes versus discharge summaries? Is there any better definition we can give than what we have given?
I don't think that we have driven the industry to be clear about progress notes versus history and physical documents. I'm going to say documents instead of notes because I think we're going to hear from Emma Jones soon some clarifying information to help us understand the difference between documents and clinical notes. So I think for the document types that are defined for exchanging encounter and patient summary information, it is not prescriptive yet as to when a progress note would be appropriate versus when a history and physical note versus a discharge summary. And primarily those distinctions track back in history to when transcriptionists were naming notes by those different types. And initially some studies were done to see what sections of information exist in different kinds or types of documents. And that's how those original document types got established in consolidated CDA back when it was just like version 1. But as you know, all the document templates are open templates, and the number of, the kind of sections that are used and suggested as being required or recommended or optional don't really restrict you from putting a section in a progress note that that the spec doesn't call to be there. So I'm less hung up on, is it a discharge summary or is it a progress note or is it a history and physical? More it's about picking an appropriate vehicle for sharing the information that collects during that kind of encounter.
Right. That's a good point. I should point out that we have multiple work items in this group, and one of the work items that we haven't been able to really get to that I would love to speaks to if you have use case X, and what are the available vehicles A, B, and C that you can use to represent that. So if you, right now, as far as this group has gotten, is we've said for encounters, if it's an inpatient, then use a discharge summary. If it's outpatient, use a progress note. And while understanding that we may evolve that, but in which cases is it okay to use a CCD, even though it's really for something else? I'd love to see just a table that says good, better, best, or should not, or something where it's, if you have this situation, use this document, and yeah, you can use this one, but it's not best. I'd love to see that.
That's a good companion guide. I mean, can we come away from this conversation, Joe, with an ask that says one of the things that we want to do is to try and get people to understand which kind of document might be most appropriate in certain circumstances to share the information.
So this is Brad. I just want to jump in. I mean, part of the joint document content worker recommendation was let's get encounter documents rolling. And I think, if folks on this call are saying, hey, our systems support discharge summary and we send progress note and let's start delineating beyond those, I'm all for it. But I think to me that I don't want to lose beating that drum of let's get encounter summaries flowing, let's get CCDs flowing, and then go beyond that. And in terms of draft documents, I think it's incredibly hard to say a draft document of this note type is more valuable than this note type. I don't think we'll ever come to agreement on that. I'm hoping the information blocking clarifies draft notes. I know some clinicians on the joint content work group said, I got to have access to those. And so I'm hoping ONC policy can help clarify that. I think it's a tricky thing for this group to say.
So Brett, I know I understand tricky for this group to say, but we're not getting a whole lot of guidance out from what's being posted from ONC. This is Rachel, by the way, sorry. And what our clients are asking. I have very specific cases in the last couple of weeks about it. What is a procedure note used for? And should I stop using the memos that I'm putting in my direct message and start using a procedure note to tell the person why I need them to do this procedure and give additional information? Should I put it in the CCDA as a note section? They don't know where. They're creating these notes in their system already, some of them.
Sure.
But they're trying to conform so that's interoperable. And where do we put this information and what document's the right document to send? They don't want to just send a CCDA because it meets the measure or it gives them a count for, promoting interoperability. They want to make sure they're communicating using the right documents. And there's not much guidance out there right now
Rachel,
to help facilitate that.
Yep, and that's super fair. And I think I'm hoping when Emma talks about clinical notes, I don't want to jump into that too much, but I absolutely agree. And in this group to set up that conversation a little bit is I know Lisa will hold me accountable and others too, is when we're talking about notes, let's make sure we're talking about notes. We're talking about the notes being into documents. And I apologize. I know some of you know exactly what I'm talking about. The CCDA has, all these different document types, and we have the procedure note document, and, very few, if any, vendors support that. But when I say procedure note, when I say, imaging note, pathology note, I see these folding into some of the major CCDA document types, such as discharge summary, progress note, and CCD.
Can I just say, and this is Emma, I think a lot of this conversation is really about it depends. Number one, the person creating the document or the system generating, the creator, generating the document. It depends on does their system have the capability of doing structured data that will satisfy the procedure note? If they're capable of doing that, then do it. Number two, your intended receiver, does your intended receiver need structured data, structured procedure notes in order to drive semantic interoperability? So you have to take in account, where
Okay.
are you sending these structured procedure notes to? Will it help to drive order entering or satisfy the fact that the procedure was completed, the procedure was done, satisfy the fact that there weren't any complications and all those other downstream kinds of things. To me, as long as the user knows what the recipient or how the recipient may use the data that they receive, then that kind of determines, and if your system is capable of creating it, the need to be able to create these structured documents that that falls under the different use cases.
So Emma, that's a really good point.
That's
And I
true.
would say that in our use case, this is a query use case. So we haven't actually explored ways in which the system requesting or the person requesting conveys special requirements about the level of detail. Right now, it's more like, I'm looking for encounters. Give me what you've got. And
this is my question though.
Yeah.
When you as a user, you're looking for encounters, give me what you got. When you receive those encounters from me, are you going to use any of the information I send in that encounter in a semantically interoperable way? And if not, do you just want to view and read about the encounters?
Right.
Will that slow your users down if I'm sending you things that you cannot use structurally? So when you say just give me the encounters, what are you going to be, do you want encounters that are usable when you get it in your system?
Right. Well, what I'm saying is that we haven't gone to the detail of defining different levels of like generate put this much data in an encounter summary in this case and put this much data in that case. Right now, if it's inpatient, return a discharge summary. If it's outpatient, return a progress note. Brett, do you want to speak to that? Is there an ask that I'm missing?
Well, no, I don't know if it's so much of an ask. I think if you query me, what are you expecting me to hand back to you?
Well,
Right?
in this diagram, just well, first off, I would say what we're not showing here is that the requester might be filtering what they're asking for by a LOINC code. So they might specifically be looking for discharge summaries, okay? But once they've specified that, really the only extra filtering that they might be indicating is a date range. And so they're interested in encounters in discharge summaries that fall within this time and this time. And beyond that, we don't have any special requirements besides just generate the documents and return them.
And I think what I'm asking you is, should you? And
Yeah. And I'm asking, yeah, same thing.
No, and the reason why I'm saying
I
should
think
you, are you a Medicare system that you just want to check the box and say, yes, this doctor generated a discharge summary, and I'm just checking the box to know that, my patient, the patient that I'm paying the bill for, they were able to get a discharge summary upon when they got, when they were discharged? Or are you a primary care provider that wants to know the discharge meds the person was on when they got discharged?
Yeah.
Right. And Emma, and this is where I think the work group, there's a few clinicians on the phone, and I think on that call, and I think we try to focus on the clinical use case of the primary, the primary care provider wanting to know the discharge medication list and the latest status of that patient. And I think, kind of speaking out loud a little bit here, I think the delineation of inpatient and outpatient may be helpful. That, for the hospital, we know the discharge summary note, just takes some time to write. And so sometimes the patient's discharged and we know that note comes later. And so I feel like we may want to, in the end, Joe, think about guidance of, for inpatient, you expose the draft when they've left the hospital. And, it's not final until the full note and the full, it's not final until that note is in there also. And maybe there's something slightly different for outpatient. I'm not sure.
Well,
Mhm.
even on the inpatient side, the person may leave the hospital today. They may not get everything, the system, the hospital system may not have, they still have outstanding lab results and all those different things. But that person is going home and they need to be followed up with. So whoever's following up, that's going to do the follow up, don't have time to wait the 30-day rule that whoever has set on the hospital to have these things. Those are administrative type processes. Now for the clinical type processes, is whatever's available today good enough for me to send to the next level of care so that so this patient doesn't fall through the cracks? And that's why, we just have to take care, and as we set up these rules, to say, oh, the discharge summary is not going to be finalized based on this 30-day process thing, so I'm not going to release it. But then the patient's already gone, and they need to be follow up, maybe within 24 hours by home care, or within 40,
Emma, I have use cases even tighter than that, right? Because you bring your mom home, and
Yeah.
the nurses at the assisted living center say, well, did she get these meds this morning, or do I still need to give them to her?
Or the home care nurse have to come out with
You
Joe.
have to know.
So it sounds
Here's
like
the summary. Discharge summary documents have to be available in draft form.
Yep. Yeah,
Period.
that's what I'm
I'm
hearing.
going to say that, and I don't know we do thumbs up, thumbs down, but that's my response to this, hearing Emma and Lisa.
Right. So if you look at the requirements that we've written, it's saying any of the following is true. So it seems like your use cases are satisfied, because if you need it the morning that the patient is released from the hospital, that would be the first case. The end time for the encompassing encounter is defined. It may not have been authenticated, it may not have been completed, but we're requiring that as soon as that patient's discharged, that you can return a draft copy.
And that goes for any encounter summary, not only discharge encounter summary.
Right.
I could have had a doctor's visit
Right.
today, an outpatient ambulatory care visit today, and he, did whatever he needed to do while I was there, and
Right.
changed my meds or documented what he could. Then he went off to play golf with intention of completing my note tomorrow or tonight. Well, I start having problems, and I go to the ED.
Right.
And the ED wants to know what's my most recent, encounter information.
Well, it sounds like, it sounds like we've met that.
So
it's not just discharges, encounters.
Okay, so these requirements meet your needs, right?
Right.
So on that point, what does responder may really mean here in your world, where it sounds like somebody is querying for encounters?
Yeah.
Are you going to, if there's no way for them to say, hey, I want in-process encounters, what does it mean that responder may? I mean, if I can't articulate that,
right,
how do I even know what I'm getting?
We don't have a mechanism yet what we mean by responder may is that it's up to the responding system, meaning if the EHR wants to have a button that the physician hits that says, share this even though I know it's just the very beginning of the encounter.
So you're getting a query and you're sort of forwarding that on to an EHR and saying, do you have anything?
Yeah, these are requirements on the responding system of what they do at the time of a query.
Okay. Is there an Sorry.
Go ahead, David.
Is there an administrative use case for a longer term stay that requires an in-process encounter to be returned? So I'm thinking of interim billing scenarios where patients in the hospital more than 30 days. I don't know if this is a real thing or not, but certainly from a claims perspective, a claim would get generated even though that encounter is not done. Right? There'd be a series of claims for that inpatient stay because the provider wants to get paid, right? I don't know if there's scenarios where if a payer or some administrative use case was querying you, the may almost becomes a shall for those in-process encounters.
If there's a use case where we would turn the may into a shall, we need to hear that use case, yeah.
Yeah,
Like,
I'm not sure that what I described is real from the perspective of needing documents, but you know, what I'm sort of the analogy I'm using in my mind is interim billing and claims, where a provider is going to go ahead and bill for that encounter even though it's not done. And I wonder in those scenarios if payers might need documents before the encounter is done.
right. I mean, right now we leave it all up to the discretion of the responding system.
Right.
If we
You've gotten a
need,
query and you're going to somebody else and saying, give me your encounters, and you got to decide what's acceptable to give me or not, right?
yeah, up until the end time of the encounter, we leave it up to the responding system. After that, it's a shall. So,
So Joe, this is Lisa. Here's a use case that has a lot to do with patient right to access.
Okay.
Elderly parent goes in the hospital. They're going to, they're there for like a week. And as the designated daughter, I'm in a situation where I want to make sure that mom is getting the meds that she's supposed to get and not getting meds that she is not supposed to get. So if I do my EHR query and this system says I only have to give you back data for encounters that are over, then I, as a right to access my mother's information, assuming, of course, that she has appropriately given me, Lisa, the right to access her information. Now I can't check to see whether the right thing is going on with her meds or not.
right. So a question that I would have for the group is, assuming you need to provide that information, would you want to say, we can solve that problem, and the way you solve it is by requesting the CCD, which is, up to the minute? Or would you like to solve that problem by requiring sharing the encounter that is in process, or both?
I mean, gosh, Joe, this is so hard because I just, I hear Lisa, I look at Dr. Lane's comment. I mean, you want to be able to give the in-process, you want to be able to give the in-process care that's occurring. I don't know how to say, it just seems like it's an absolute must, and we just have to figure out how to put the right parameters on it where systems can say it's unsafe, or there's sometimes reasons they can hold it back. And so maybe that'll come out of policy guidance at ONC, but I'm just thinking maybe we flip this on this head and say, let's say everyone, sorry, I'm going to say in the affirmative and people can argue. So every system needs to be able to respond to encounters that are in process. They can mark a draft, they can do whatever they want, but how do folks respond when we say this sort of shall?
Before you answer, what if we were to define some kind of a flag where in the request that says, I'm looking for encounters, and by the way, I'm interested in process?
Well, that doesn't take care of the clinical concern, but I hear so if you had something that was clearly marked as draft, and I guess I'm asking this of Stephen, what his opinion is of this. If something was marked as draft, so in other words, draft meaning there is likely or there may be inaccurate stuff in this note because it's draft. Does that from a legal perspective, and I think that's what we're thinking of as clinicians, not just legal, but also you don't want inappropriate care to be provided, right? So you have to have something that says, hey, have this document if you want it, but I'm not guaranteeing its accuracy.
Yeah, I can happily respond. My feeling is that inside an organization, I can view people's progress notes in progress that are unfinalized. So if my patient happens to be hospitalized at a hospital in my system, I can go see that data. However, if they're at the hospital across the street that's in another system, I don't necessarily have that opportunity, unless I've got portal access or something. So I think that's the concept. I think clinicians understand the idea of data in progress. They understand the idea of a non-finalized note, and we can typically sort out, okay, I can read the history, or I can read the physical, and I can see whether it's just an incomplete template or if it looks like they've actually observed something. And that's important information. That beats having to pick up the phone and find somebody and ask them what they were thinking or what they were doing or what they saw. So I personally think that it's okay to release in-progress documents or documents that include unfinalized data, so long as it is called out as such. Other people disagree with me.
do you want to see it before, do you want to review it before it goes out? Or is it okay for us, and I'm not speaking mostly with implementation hat on, can I park it somewhere where they can quit, you know, anytime you're entering your data, you see it's not finalized, you're waiting on stuff, I'm assuming you click save and you go about to the next patient. Then I take that wherever you're at, that document, and I put it somewhere, or, you know, as it is in the existing place where you stopped at. I get then 20 minutes later, an hour later, there's a query that comes in for it. Do you want to see it again before it goes out, or can we just send it out?
Again, my personal feeling is that, you know, as you said, if somebody's off playing golf and their patient's in the
Or they're
ER,
busy, they're seeing another patient.
yeah, whatever it is, whatever it
Yeah.
is. I mean, when I send my patient to the ER, if I got pulled away from my note before I had a chance to sign it, I want that data to be available to the ER.
Okay.
So
I have a
I don't
question.
think the idea of having an extra check in there makes sense from a patient safety perspective.
Right, right. I agree with Stephen. I think so
Because that would
long as
increase
the,
burden.
you know, it's clearly identified as draft, then, you know,
A question for you. Do you think that sharing incomplete data can be done under existing HIPAA law, or whether you would have to maybe consider a higher level, you know, policy?
I don't
But
think
Joe,
that
let's go
HIPAA
back.
limits that. Go ahead, Holly. Sorry.
So first of all, Emma, I don't like the idea of parking it before and sending it only after someone's reviewed, because that may be hours.
Yeah.
Well, in terms of your question, Joe, go back to Steve's use case. I'm working at the Cleveland Clinic. I send my patient to GI. I can see that note as it's being written. So
Right.
we're just talking about outside of the institution. So I don't see if you can do that inside, how it could possibly be a HIPAA violation if you're doing that outside of an organization. Because you're all caring for the patient. You're on the patient's care team.
Right. So as long as we mark, as long as it's clear from the document by looking at the document that it's in process, and you can see that you know, there's no end date for the encounter. You can see it's not been legally authenticated. Then under HIPAA, everything's okay. Sounds like.
Joe, you're raising two interesting points because they're quite different. One is that the encounter is actually in progress, that it's not been completed.
Right.
The other is that the document is not signed.
Right.
So if all the discussions we had in the joint document meeting, there are docs that don't sign their charts for months. I mean,
Right.
for weeks. Even though the encounter's been completed, they, you know, and this is in an electronic health record, they just don't sign. So I think they're two quite different things, and we really should have flags for both. That the encounter's completed, but the document is not signed, and then the
Right.
encounter's in.
Well, they are independent fields in the CDA, so you can see the difference. You could
But I think
render that to a user.
Those should be musts. That those have to, as they go out, that those fields have to be completed. So that the person that gets the document knows, oh, the encounter's not even completed, or the encounter's been completed, but the document's not signed.
Right. It's more the lack of presence. Like if legal authenticator is not there at all, then the document's not considered legally authenticated. It's not a positive, this is not complete. It's just the lack of presence of it. Yeah, I know we're at time. All right, this is a really good conversation. I wish we could go for another couple hours. What I want to show you at least is the rest of the stuff that we talked about, that not good to throttle new versions, good to return the same document if nothing's changed. So this is less to do with CDA and more to do with dynamic behavior. If you're interested, you can look at the slides. And then I had some next steps, which were not even related to this, but I want to get them in front of the group. Maybe we can revisit these later in the day. We need a results section in the discharge summary. So that's something we'd like to see. We'd like to know how to connect results to the original order. we know that there's the in fulfillment of that lets you have an entire document to be in fulfillment, but we would like to connect lab results that are just part of a larger document to the original order. I think I may have seen something in the new companion guide that talks to that.
Joe?
Yeah.
Are you saying that you would like to have some guidance with respect to your previous slide? What was it, the discharge
Yeah.
summary? Because you can add. I mean, it's an open template, so a result section certainly could be added.
Right. It's true you can add, but given that there's a discharge studies summary section, we wanted to know from our end if we were layering requirements on top,
Right,
would it be okay to require the addition of the results section? You know. Yeah, and then there's some lab life cycle things that we wanted to deal with. So this generally has to do with a lab shows up in a CDA and then it's modified somehow in a subsequent CDA. So you might have a lab result and results with canceled, or do you put canceled on the lab order and plan of treatment, or you do both? And then how do you correct a lab result in the subsequent CDA? How do you tie that to the original result? I mean, these were things that we brought up the last IAT, but they've turned into these concrete questions that I would hope this group can address at some point. Okay.
Right.
That's pretty much it.
All right. Thanks, Joe.
Thanks, everybody.